All right, hey everyone, and welcome. Today, we're jumping into a condition you absolutely have to know inside and out, not just for your exams, but for your future practice, mucous membrane pemphigoid. We're going to use a real-world patient case to break down what it is, why it happens, how you spot it, and what you do about it. And hey, for more deep dives like this, you can always check out the Master Oral Path YouTube channel. Let's get started.
So picture this, a patient is in your chair, they're clearly uncomfortable, and they tell you this. Their gums are literally peeling away and bleeding with just the slightest touch. This is a huge red flag, and it's definitely not just about brushing too hard. This single complaint is our doorway into understanding a really important autoimmune disease.
Let's treat this whole thing like a clinical investigation. The patient's symptoms, those are our clues. And that main complaint, that chief complaint, points us straight towards a group of conditions we call vesiculobullous diseases. And one of our top suspects has got to be mucous membrane pemphigoid.
So what in the world is mucous membrane pemphigoid, or MMP for short? Well, it's a chronic, autoimmune, blistering disease. Now, the two keywords there are chronic and autoimmune. This isn't some infection that's going to go away with a course of antibiotics. No, this is the body's own immune system getting confused and attacking its own tissues. And since the mouth is ground zero for this disease most of the time, it's up to us in the dental field to be the first line of defense.
And that leads us to the million-dollar question. Why? Why are this patient's gums peeling off? To figure that out, we have to zoom way in, down to the microscopic level, and look at the pathogenesis. This is where we see exactly how the immune system goes rogue.
Okay, so here's the play-by-play. It all starts with some kind of trigger, and honestly, we're still not totally sure what it is. In response, the body starts making these things called autoantibodies. You can think of them as misguided soldiers. Their new incorrect mission is to attack the very proteins that act like Velcro, holding our top layer of tissue, the epithelium, to the connective tissue underneath. When these antibodies hit their targets, that Velcro just lets go. The result? A clean split. That new space fills up with fluid, and boom, you've got a blister, or what we call a subepithelial bullae.
Okay, so that's the crazy stuff happening on a tiny scale. Now let's zoom back out. How does all that translate to what you're actually going to see in the clinic with your own two eyes? Understanding the why makes spotting the what so much easier.
Think of this as your clinical cheat sheet. First off, your typical patient is going to be an older adult, and it's a bit more common in women. The classic look is something we call desquamative gingivitis, that fiery red, angry, peeling look of the gums. Now, because the blisters that form are so fragile, especially in the mouth, they pop almost immediately, leaving behind these really painful ulcers. This fragility is also what leads to a positive Nikolsky sign. This is where you can apply a little gentle, sideways pressure to normal-looking tissue nearby, and if it just sloughs right off, that's a huge clue you're dealing with this disease.
Now listen up. If you remember one thing from this entire explainer, please let it be this. This is non-negotiable. The same autoimmune attack that's happening in the mouth can happen in the eyes. And when it does, the scarring can literally cause the eyelid to fuse to the eyeball. It's a condition called symboltherin, and it can lead directly to blindness. So I'll say it again. A diagnosis of oral MMP means you pick up the phone and make an immediate referral to an ophthalmologist. No exceptions.
All right, so you've seen the clinical signs, your suspicion is high. But a hunch isn't enough, right? We need definitive proof, especially since other conditions can look a lot like this. To really lock in the diagnosis, we've got to turn to the lab.
We rely on two main tests, and they each tell us a different part of the story. First, a standard biopsy. This reveals the problem. Under the microscope, we can see that clean split right where it's supposed to happen, just below the epithelium. But that doesn't tell us why it's split. For that, we need the test on the right, direct immunofluorescence, or DIF. This is our gold standard. This test uses fluorescent tags that light up wherever those rogue autoantibodies are. And in MMP, what you see is this beautiful, continuous, glowing green line right along the basement membrane. That line is our smoking gun. It's the definitive proof.
So knowing how to confirm MMP is one thing, but just as important is knowing how to tell it apart from its lookalikes. And in the world of blistering diseases, the classic showdown, the one you'll be tested on forever, is pemphigoid versus pemphigus vulgaris. They can look really similar in the mouth, but on a molecular level, they are worlds apart.
This table right here, this is pure exam gold. Let's walk through it. First, the target. In pemphigoid, the attack is on the basement membrane, the foundation. In pemphigus, the attack is on desmosomes, the little spot welts that hold individual cells to each other.
Because of that, the vesicle location is different. Pemphigoid is subepithelial, below the layer. Pemphigus is intraepithelial, right in the middle of it. This also changes the DIF test. Pemphigoid gives us that clean, linear band. But pemphigus, it looks like a fishnet, with the connections around every single cell lighting up. And finally, prognosis. Pemphigoid can cause serious problems, like blindness, but it's rarely fatal. Pemphigus, on the other hand, can actually be deadly if you don't treat it.
Okay, let's get back to our patient. We figured it out, we've confirmed the diagnosis, we've ruled out the mimics. The big question now is, how do we help them? What does treatment look like?
First thing we need to understand is that our goal is control, not a cure. We're just trying to manage the faulty immune response. For mild cases that are only in the mouth, we often start with high-potency topical steroids, and a great way to deliver them is with a custom-made tray that keeps the medicine right on the gums. For more severe disease, we have to pull out the big guns, systemic drugs like prednisone that calm down the immune system throughout the body. And don't forget this last part, it's a huge adjunct to treatment, impeccable oral hygiene. Keeping the mouth clean reduces inflammation and helps those steroids work way, way better.
I love this quote because it really captures what the patient goes through. This isn't a take this for 2 weeks and you're done kind of thing. It's a journey. Patients are going to have good times where the disease is under control and bad times where it flares up. A huge part of our job is managing those expectations and being there for them for the long haul.
So as we wrap up, let's hammer home our most important takeaway one more time. While MMP usually isn't going to kill someone, the potential for serious, life-altering problems, or morbidity, is very real. And that scarring of the conjunctiva leading to blindness is the absolute worst-case scenario. This is why our role in catching it early, diagnosing it correctly, and making that ophthalmology referral is so incredibly important. It can literally save a patient's sight.
And that leaves us with a final thought to chew on. Right now, we manage MMP by kind of carpet bombing the immune system, but as medicine gets smarter and we develop more targeted therapies for other autoimmune conditions, you have to wonder, right? Could a real cure for diseases like MMP be just around the corner? It's a really exciting time to be in this field. Thank you so much for watching this explainer. For more content, don't forget to check out the Master Oral Path channel on YouTube. I'll see you in the next one.